My name is Ahmad Kifari. I'm so happy today that I will be your host and also the moderator for Professor Uwe. So before we start, I will read today's schedule for the occasion. So first, our Dean, Dr. Yanti, will open with the opening remarks. And second occasion will be the presentation by Professor Uwe. So we can start to go on the first schedule to Dr. Yanti. The time is yours.
Thank you, Dr. Gifari. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good afternoon in Indonesia, and good morning, and welcome to Professor Dr. Groβ
Thank you very much.
From Göttingen University.
I'm very happy to join you.
Hello,
Thank
Dr.
you for your time as speaker in guest teacher and guest lecture, Faculty of Medicine, Universitas Muhammadiyah Palembang. I'm sorry, I'm in bahasa. Selamat datang pada semua peserta yang sudah bergabung pada siang hari ini. Puji dan syukur kehadirat Allah Subhanahu wa Ta'ala karena di hari ini kita semua diberi kesehatan dan kesempatan untuk bertemu dalam kegiatan kuliah tamu di Fakultas Kedokteran Universitas Muhammadiyah Palembang. Salawat dan salam tidak hentinya kita haturkan kepada Nabi kita Muhammad SAW. Semoga kita semua akan mendapatkan syafaat di yaumil akhir. Seperti kita ketahui, pemerintah melalui keputusan Presiden tanggal 31 Maret 2020 itu telah menetapkan kedaruratan kesehatan masyarakat akibat COVID-19 ini di Indonesia. Kondisi pandemi COVID-19 mengakibatkan banyak sekali perubahan yang secara tiba-tiba dalam keseharian kita sebagai individu maupun aktivitas kita sebagai masyarakat yang membawa dampak yang luar biasa ya, hampir di semua bidang. Situasi terkini kasus COVID-19 secara global ini untuk di dunia per tanggal 9 Februari 2021 itu sudah kalau tidak salah mencapai 106 juta lebih dengan angka kematian ya 2,2% ya. Nah, untuk di Indonesia sejak pertama kali kasus konfirmasi positif pada tanggal 2 Maret 2020 itu terus terjadi peningkatan. Ya, data terakhir pada tanggal 9 Februari 2021 itu sudah mencapai 1,1 juta lebih kasus. Dari 6 sudah 6,5 juta spesimen yang diperiksa. Dengan angka kematian lebih kurang 2,7%. Ini merupakan kasus yang tertinggi di Asia Tenggara sekarang ya. Nah, salah satu penilaian atau indikator keberhasilan penanganan kasus pandemi di suatu negara itu adalah rendahnya angka positif rate. Apa itu positif rate? Itu jumlah kasus yang positif dibandingkan dengan seluruh orang yang diperiksa. Kalau dari WHO itu menetapkan ambang batas untuk positif rate itu sekitar 5%. Nah, kalau Indonesia bagaimana per data yang tadi saya sampaikan untuk tanggal 9 Februari 2021 dengan jumlah kasus yang sudah sampai 1,1 juta dan spesimen yang diperiksa 6,5 juta, itu angka positif rate-nya tinggi sekali ya, masih 16%. Nah, sehingga agak sulit dikatakan kalau Indonesia sudah berhasil melewati pandemi. Nah, dikatakan bahwa kita saja belum bisa melewati pandemi yang gelombang pertama. Nah, apa yang dimaksud pandemi gelombang pertama? Apa indikator terjadinya pandemi gelombang kedua yang seperti dialami beberapa negara lain itu sudah mengalami yang gelombang kedua ya. Untuk itulah tujuan kita mengadakan kuliah tamu pada hari ini. Pembicara akan menjelaskan lebih lanjut tentang pandemi COVID-19 gelombang kedua dan bagaimana cara mengatasinya. Saya berharap kuliah tamu hari ini memberi manfaat bagi kita semua. Thanks again for speaker, Prof. Dr. Groβ. I wish the success of this great lecture through this webinar. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Yanti, for opening today's international guest lecture. Dr. Yanti was talking about the Indonesian situation, which is we have not finished our first wave yet, and maybe Professor Uwe can share how German tackled in COVID pandemic. So we now can go on to the second part of this today occasion. So already in our midst, Professor Uwe Gross. And before we start the presentation, I will briefly explain some of the procedure for the events. So the presentation from Dr. Uwe will be held for 45 minutes and followed by question and answer, approximately around 30 minutes. To all participants, you are invited to prepare the question both in English, or you can do it also in Bahasa. I will try to translate it to Professor Uwe, or maybe Professor Uwe can still remember some Bahasa.
Oh no, I'm very sorry.
It's been a while, yeah. Okay, so you can put your question in Zoom chat, or also you can put it on YouTube channel. So I will remind you again that today is a very rare opportunity that we are able to directly follow presentation from Professor Uwe Gross, and also have the chance to ask okay. Anybody can hear me? Professor Uwe, are you here still?
I am still here and I can hear you. But now you are gone. I see all
okay,
the
thank you. I will go on. Yes, so we have some problem in Zoom. Now, as you can hear me, I will continue reading some of the CV of yours. So I will repeat it again that today is a very rare opportunity that you are able to directly hear Professor Uwe Gross' presentation and have the opportunity to ask directly to him. So before Professor Uwe okay. Speaker. Hello. Okay, I can see Professor Uwe Gross CV. Anybody can hear me?
Yes, we hear you, Dr.
I can
Okay.
see you and hear you.
Oh, okay. I think I have some internet problem. So I will continue here. So, oh, my internet connection is unstable. So today, Professor Uwe Gross will explain the COVID-19 from the perspective of microbiology and also from the clinical perspective, some history about pandemic and also the coronavirus itself, which is SARS and also MERS. Professor Uwe also will explain the detection technology regarding detection or diagnostic of this. And lastly, Professor will share how to tackle the second wave from the experience in Germany. So before we start, I will read some of Professor curriculum vitae. So first, Professor medical education is from University of Hamburg in 1980 and graduated in 1986, and then continued to the doctoral program as Dr. Med in University of Hamburg in 1987. Third, taking the diploma of tropical medicine and medical parasitology in Hamburg in 1992. Today, Professor Uwe is the head of the German National Consulting Laboratory for Toxoplasma and also some AIDS. Currently, Professor serves as member of working committee in the government agency, the Federal Bureau for Family and Civil Society Task, Berlin, Germany. Professor Uwe also was a chairman in the AAD Physician Program, Indonesian-German Health Education Partnership. This is the occasion where I first met Professor Uwe, and I have the chance to go to Germany to do some study in Germany. 7, Professor Uwe also a board certificate member of microbiology and infection epidemiology in Medical Council. And now Professor is a full professor of medical microbiology at Göttingen University from 1990 until now. So to add some his recent publication in the Impact Journal related to COVID-19 and also Toxoplasma and also this Clostridium difficile, first published in Nature in 2020 regarding remote near-infrared identification of pathogens with multiplex nanosensors. As I see your presentation, you will talk about this paper too. And second, publication in Diagnostic 2021, comparison of 5 serological assay for detection for SARS-CoV-2 antibody. Number 3, in 2020, the Journal of European Journal of Microbiology Immunology, evaluation of Xiamen Amon Med Bio Rapid Test COVID-19 IgM-IgG test kit. Publication in 2019 in Frontiers Proteotyping of Clostridioides difficile. And lastly, the Clinical Infection Disease Journal 2012, efficacy of rapid treatment initiation following primary Toxoplasma gondii infection during pregnancy. So We have today Professor who has many publications and also well known for COVID-19. So now for the time and place, I invite Professor Uwe to present the presentation around 45 minutes. Professor, please, time is yours.
Okay, first of all, I thank you very much for the invitation. I hope you can see now my presentation. If that is the case,
Yes,
I
can see.
Can start. Very good. So I will give a presentation, not 45 minutes, it will be more near 60 minutes, I guess.
Okay.
I will talk about SARS coronavirus 2, which is causing the disease COVID-19. Very often people mix up these two names. SARS-CoV-2 is the name of the virus, and COVID-19 means coronavirus disease 19, because it was first described in the year 2019 in China. First of all, when we look into coronaviruses, we have to be aware that these viruses are positive RNA viruses, meaning that the genome consists of mRNA, and it has a very large genome, about 30,000 nucleotides, with a total size, when we look to the virus particles, of 80 to 120 nanometers. So it's a quite large virus and virus particles. The human pathogenic alpha coronaviruses are classified into two groups, alpha coronavirus and beta coronavirus. And they were first described about 60 years ago. And as you can see, these four coronaviruses, they are usually causing mild respiratory infections. Up to date, it's not quite sure whether they also cause enteritis, because sometimes they are discovered in the gut, especially in patients with enteritis, but still unknown whether they are just shedded by fecal specimens or whether they are really the cause of the disease. These four coronaviruses are harmless, and they are transmitted from human to humans, usually by droplets or by aerosols. Quite recently, we have the emergence of three more serious and dangerous coronaviruses. These three coronaviruses, SARS coronaviruses, causing severe acute respiratory syndrome, that's the abbreviation SARS, or the Middle East respiratory syndrome, that's caused by MERS coronaviruses, and just recently SARS coronavirus 2, which is causing COVID-19. At the moment, we are sure that these three dangerous coronaviruses are zoonotic, have zoonotic potential. The original reservoir is found in animals, and in quite a few minutes, I will talk about the natural reservoirs, the transmission routes, and so on. Before I focus on SARS coronavirus 2, I will shortly describe the other three dangerous coronaviruses. About 20 years ago, in the year 2002, in the province Guangdong in China, the first patients were presented, which had a very severe respiratory syndrome. They had problems in breath. And all in all, they had a death rate of about 10%. Starting in Guangdong, this viral disease spread over the globe within a couple of months. And up to date, we have about 8,000 infections and 800 deaths. At the moment, we are quite sure that this pandemic is gone, is over. It took only 6 months, and especially the very rapid response by for the of this virus to North America, to Europe, and to other continents as well. Here you see it started in China and then it spread to Southeast Asia, to Australia, to Europe, but as well to Northern America. But also to the African continent, as you can. Very important at that point of time was the rapid response. And Christian Drosten, who is the first author of this paper, he was the person, his scientist in charge, who identified SARS coronavirus. I know him quite well. At that point of time, he actually was a doctoral candidate. So he was very young at that point of time. He worked in Hamburg in the Tropical Institute, and he heard about this viral disease. And he as well was aware that the day before, one patient arrived in Frankfurt Airport. So he was sitting in the train to go to Frankfurt Airport, and he asked the colleagues, is it possible to get a specimen of this patient? Because I'm interested in this disease. So with this sputum sample, he returned by train back to Hamburg. And he told me later during the night, he tried several primers, several PCR test systems. And finally, he was able to identify that the cause of the disease is a new coronavirus. So instead of waiting for publication and so on, he immediately placed the recipe for this PCR in the internet so that everywhere on the globe, everywhere on our planet, people were able to detect, to diagnose the disease. And this actually was so important to stop the spread of the further disease. So the young students, the audience, you can see that even if you are young, if you have good ideas, it is for the general society. Directly humans. Still now, although we are 20 years later, it's still unsure whether civet cats, for instance, also can directly infect humans. However, we know that bats are the original reservoir, and very quickly the virus adapted to the human beings and was able to be transmitted from human to humans by aerosols, by droplets, and so on. Diagnosis for this disease still is based on RT-PCR from respiratory specimens. The therapy for the original SARS disease is quite difficult. And in some cases, ribavirin is quite successful. This is a nucleoside analogon, which is able to inhibit the RNA polymerase of the virus. So we know that bats are quite important for coronaviruses. And actually, many scientists, including Christian Drosten, they spend months of the year in the African continent to analyze bats to identify new coronaviruses. And we now know that all life-threatening coronaviruses have the origin in bats. One reason why bats do not get sick, they have a specific immune system which is able to control the virus in a very specific sense, so that they just transmit the virus without becoming sick themselves. About 10 years later, you see 2012, another virus emerged, and here we had the specific finding that this virus is present in Saudi Arabia on the first step. Now we have about 2,500 infections worldwide, about 900 deaths. So we have a death rate of 35%, meaning every third people who got infected will be killed by this virus. And this pandemic still is ongoing, so it has not been stopped. We know that its origin comes from Saudi Arabia. And in contrast to the original SARS coronavirus, MERS coronavirus is not only causing respiratory syndrome, but also renal failure. So we have a combination of lung disease and kidney disease in this MERS coronavirus. MERS coronavirus, as you can see here, at this point of time when this publication came out, it still had another name. This MERS coronavirus is closely related to the original coronavirus, as you can. They are quite closely related and form one close family. As you remember, the first cases were published in 2012, and only one Center for Disease Control are very quickly able to adapt to new hosts, in this case to humans, transmitted from one nation itself. As I mentioned, everything started in Saudi Arabia, and some of you maybe have been in this area. Here we have the United Arab Emirates, and we have quite important airports, which are crossing points in international air traffic, like in Dubai, like in Doha, Qatar. And by this location, just by having close proximity to airports and international travel, very quickly MERS coronaviruses spread first to Europe and later on also worldwide. Beginning, it was quite unsure how the virus was able to infect humans and other animals. Now we know very sure that again we have bats as the original reservoir, and these bats, when they shed their feces, then these feces go to the ground, contaminate the ground, and by this contamination and maybe windy conditions, animals can be infected as well, like baboons, like domestic animals, cats, and so on. But also very important for MERS, camels. So camels also become infected, and camels actually develop symptoms. They also develop coughing and respiratory syndromes. And one problem why the virus further on spread from the camels to humans is a quite fascinating behavior of Saudi Arabic people. They like to kiss their camels. And by kissing the camels, they can be infected, they can become infected from the camel. So the Saudi Arabic government, they proclaimed and they prohibited kissing the camel. And here this is a German newspaper where it is reported that the Saudi Arabic people, they protest. They want to continue to kiss their camel. So again, this virus very quickly spread over the globe to Asia and even Southeast Asia, to Europe and to North America. So now we have the second coronavirus, which is spread by, or which has its original reservoir in bats. And quite important for you to know, bats are migrating animals. They can fly, and they are animals which can fly over very long distances. It is known that bats who usually live in this area in West Africa, they fly over this distance through Arabia, through Asia, down to Australia. So one bat is able to fly over this long distance. And now you can understand that coronaviruses have the origin not only here, they have the origin here. And I'm quite sure that many coronaviruses, new coronaviruses, which we still do not really know, have the origin here. So as the scientists, we just wait for new coronaviruses coming and entering the scene. And finally, now I come to our main topic, and this is COVID-19. And as you can see, on the last day of 2019, the WHO China country office was informed by Chinese scientists that in Wuhan city, in the Hubei, China, people were become sick. And at that point of time, a total of 44 patients with pneumonia of unknown etiology have been reported. Later on, it was found out that all these people had some sort of association with a fish market in Wuhan. And on this fish market, several different animals were sold as well. And people very quickly thought that these animals might be responsible for spreading the disease. Very quickly indeed, already in March, the first publication on this new coronavirus was published by Chinese scientists. And this coronavirus, because it caused also a severe acute respiratory syndrome, was called SARS coronavirus 2. At that point of time, many people had some doubts about the origin of this virus because in close proximity to this fish market, there was a very large, or there is a very large research institute. And this research institute is focusing on coronaviruses. So many people thought at that point of time, maybe it was an accident and SARS coronavirus 2 indeed was a construct which was created in this laboratory. At the moment, you might know, WHO experts are on the scene in China, on the fish market. And at the moment, there is no indication that coronavirus 2 is really originated from this laboratory. So at this moment, all scientists are quite sure that this is a new type which was generated in nature and not by scientists. So again, we have the natural host, and by genomics and comparison of genomes from coronaviruses which are found in bats and from the genome of SARS coronavirus 2, there are so close associations that most scientists are confident that SARS coronavirus 2 has its original destination really from bats. And through bats, other animals are infected as intermediate hosts like pangolin and snakes. And these animals actually were sold on the fish market. So by these animals, we believe that SARS coronavirus found its way to humans, and now we have human-to-human transmission. However, humans and other animals can as well be infected, like minks, like tigers, lions, dogs, and cats. By experimental infection, it was figured out that other animals seems to be resistant against natural infection, like pigs, chicken, rabbits, turkey, and so on. And other animals are susceptible to infection. So at the moment, it is quite unsure what is causing these species specificity. One important link might be the ACE2 receptor. So when we compare the harmless coronaviruses and the harmful coronaviruses, all of these have the original reservoir in animals. However, animals do not play any role anymore for the harmless coronavirus because this viruses have been adapted exclusive humans able to infect humans and other animals. Now we know very sure that again we have bats as the original reservoir, and these bats, when they shed their feces, then these feces go to the ground, contaminate the ground, and by this contamination and maybe windy conditions, animals can be infected as well, like baboons, like domestic animals, cats, and so on. But also very important for MERS, camels. So camels also become infected. They also develop coughing and respiratory syndromes. And one problem why the virus further on spread from the camels to humans is a quite fascinating behavior of Saudi Arabic people. They like to kiss their camels. And by kissing the camels, they can be infected, they can become infected from the camel. So the Saudi Arabian government, they proclaimed and they prohibited kissing the camel. And here, this is a German newspaper where it is reported that the Saudi Arabians their camel. So again, this virus very quickly spread over the globe. To Asia and even Southeast Asia, to Europe and to North America. So now we have the second coronavirus, which is spread by, or which has its original reservoir in bats. And quite important for you to know, bats are migrating animals. They can fly, and they are animals which can fly over very long distances. It is known that bats who usually live in this area in West Africa, they fly over this distance through Arabia, through Asia, down to Australia. So one bat is able to fly over this long distance. And now you can understand that coronaviruses have the origin not only here, they have the origin here. And I'm quite sure that many coronaviruses, new coronaviruses, which we still do not really know, have the origin here. So coronaviruses coming and entering the scene. And finally, now I come to our main topic, and this is COVID-19. And as you can see, on the last day of 2019, the WHO scientists that in Wuhan city, in the Hubei, China, people were become sick. And at that point of time, a pneumonia of unknown etiology have been reported. Later on, it was found out that all these people had some sort of association with a fish market in Wuhan. And on this fish market sold as well. And people very quickly thought that these animals might be responsible for spreading the disease. Very quickly indeed, already in March, the first publication on this new coronavirus was published by Chinese scientists. And this coronavirus, because it caused also a severe acute respiratory syndrome, was called SARS coronavirus 2. At that point of time, virus, because a very large, or there is a very large research institute, and this research institute is focusing on coronaviruses. So many people thought at that point of time, maybe it was an accident, and SARS coronavirus 2 indeed was a construct which was created in this laboratory. At the moment, you might know, WHO experts are on the scene in China, on the fish market. And at the moment, too, is really originated from this laboratory. So at this moment, all scientists are quite sure that this is a new type which was generated in nature and not by scientists. So again, we have the natural host. And by genomics and comparison of genomes from coronaviruses which are found in bats and from the genome of SARS coronavirus 2, there are so close associations that most scientists are confident that SARS coronavirus 2 from bats, and through bats Other animals are infected as intermediate hosts like pangolin and snakes, and these animals actually were sold on the fish market. So by these animals, we believe that SARS coronavirus found its way to humans, and now we have human-to-human transmission. However, humans and other animals can as well be infected, like minks, like tigers, lions, dogs, and cats. By experimental infection, it was figured out that other animals seems to be resistant against rabbits, turkey, and so on, and other animals are susceptible to infection. So at the moment, it is quite unsure what is causing these species specificity. One important coronaviruses and the harmful coronaviruses, all of these have the original reservoir in animals. However, animals do not play any role anymore for the harmless coronavirus because viruses have been adapted to humans. So now today we have a pure exclusive human-to-human transmission of the harmless coronaviruses. Of the emerging dangerous coronaviruses, SARS coronavirus, SARS coronavirus 2, and MERS coronavirus. At the moment, there is quite have the original reservoir in bats. Through different intermediate animals, they have been able to infect humans, and all of them are now able to be transmitted from human to human. COVID-19 first million infections, more than 2.3 million deaths, meaning we have a case fatality rate of 2.2%, and it's an ongoing pandemic situation. Now I shortly, briefly will go into pathogenesis of, shortly will describe the virus. It's an enveloped RNA virus, so the nucleic acid is RNA. It's a single-stranded RNA, and in the envelope we have certain proteins, and most important is the so-called spike protein. I briefly will go into detail of the spike protein in just a minute. So this virus, since it is an enveloped virus, is usually exocytosed from an infected cell. For this exocytosis, quite important is an enzyme in the membrane of the host cell. In a few minutes, I will talk about this enzyme. So one important cellular enzyme is needed, is required, that the virus particle can be exocytosed from the infected cell. So this virus particle then is coming in close proximity of a new cell, and in order to bind to the new cell, we have an interaction, we need an interaction between the spike protein and the ACE2 receptor. And this ACE2 receptor is found on many cells, not on all cells. And at the moment, this seems to be a very important molecule which might explain host specificity and cell specificity of the virus. I briefly will go into more detail. So we have the spike protein, and when we look to the spike protein, this is the spike protein, then we need two important events in order that the spike protein is able to bind to the ACE2 receptor. Important event is the pre-activation, cleavage of the spike protein by a cellular protein, a cellular enzyme, and this enzyme is called furin. The second important event is the real activation, and this real activation is triggered by another cellular enzyme, and this cellular enzyme has the name TMPRSS2. Only when these two activation steps have been activated, then this modulated or modified spike protein is able to bind to the ACE2 receptor. So here we have important targets for future therapies, because this TMPRSS2 enzyme plays an important role also in pancreatitis. And there is a Japanese drug, and this drug is called camostat mesylate. And this drug is used to treat patients with pancreatitis. And researchers from my hometown, from Göttingen, they were able to show if you use this drug from Japan, you actually can inhibit infection of SARS coronavirus to human cells. So now clinical studies are underway to judge. It was intended to be used for treating pancreatitis, might also be able to treat coronavirus disease. So when the spike protein comes near to the host cell, we first have the activation by cellular proteins. Then we have the binding of the spike protein to the ACE2 receptor. And this event then triggers the invagination of the host cell. So the virus particle is able to become uptaken by the host cell. Then we have the uncoating of the viral RNA, and the viral RNA is equaling messenger RNA, so it very quickly can be transcribed and can be responsible to produce new proteins, so new spike proteins, nuclear proteins, and so on. And on the other side, this virus is producing its own RNA polymerase, and this RNA polymerase is needed to replicate the RNA. So meaning here we have another specific target which can be used for therapy. So when we use RNA, about that in more detail, then we have another strategy to treat the virus disease directly. Later on, the entire virus particles are formed, and they are spread or loosened from the host cell by exocytosis. I have much more than 100 patients who had very severe outcomes. We can really classify the situation in the patient into 3 stages. Stage 1 is the early infection stage. Stage 2 is the so-called pulmonary phase, meaning we have pneumonia mainly, isolated pneumonia. And stage 3 is the hyperinflammation phase, meaning that we have now a systemic disease, a life-threatening disease. So the key events in these different steps: in stage 1, we have the viral infection via the ACE2 receptor and the cellular enzyme TMPRSS2, which is needed for activation of the spike protein. And at that point of time, we have active replication and viral release of the host cells, which cause an apoptosis, a similar phenomenon, which is called pyroptosis. At this stage, by treating the viral infection itself, so by giving the patient antiviral drugs, we are able to clear the situation and to prevent further development of the disease. So it is very important to treat the patient at a very early stage of infection. If we miss this treatment stage, the patient will go on into the pulmonary phase. And here we now have the starting point of the host inflammatory response, meaning that pro-inflammatory cytokine release is taking place, that monocytes, macrophages are recruited to the site of infection. At a very later stage, T cell recruitment takes place. And at that point of time, our body, the human body, still has a chance to eliminate infected cells. However, if this is not successful, then the patient is further going on into the severe stage, into the red stage. And at this stage, the virus places no role anymore. At this stage, when we are in the red stage, it is our host, our hyperinflammation, our pathoimmunological response, which is causing the life-threatening disease. So here we have infiltration of immune cells, and now we have systemic overproduction of cells. And the disease is not limited to the lung anymore, but we have involvement of extrapulmonary organs, meaning a kidney might be involved, the heart might be involved, even the brain might be involved. So at this stage, since it's an immunopathological phenomenon, here we have to do something about the hyperinflammation, meaning in this stage, we have to give corticosteroids and something like that. Due to the cytokine storm and to the hyperinflammation, production in the lung. So here you see an alveoli of the lung, and we have infiltration of immune cells like macrophages, activated T cells. So we have a really hyperinflammation. And what you see in the X-rays is not the infection by the virus. All what you see here is the result of the hyperinflammation. So now we are about 1 year later. About 1 year ago, the infection process started. We had the first virus isolates, which originated from China, and the virus was able to spread over the globe. And very quickly, the virus was able to adapt to different hosts, to different situations. And the result of this adaptation are mutations. In Germany, we had the first cases of coronavirus in January last year. And in Göttingen, my town where I'm working now, we had the first cases in March. When we sequenced the first isolates in Göttingen, we already found several SNPs, single nucleotide exchanges. This is the original strain from Wuhan. This is one of the first isolates in Göttingen, and you see already at different positions, at several different positions in the genomes, we have exchanges of nucleotides, meaning the virus is very quickly able to mutate. At the moment, you might have heard about dangerous mutations. We call them variants of concern. So one of these variants of concern is the so-called UK variant, which has the numbering B117. Then we have South Africa, a mutant or variant of concern, B1351. We have a Brazilian variant of concern, and even in Japan, we have the first variant of concern. Most likely this Japanese variant has something to do with the Brazilian variant, because the relationship is very close. However, especially from the UK and the South, they can more easily bind to the ACE2 receptor. The reason is that these mutations, I will show, no, first I go to another point, that these mutations are focusing on the receptor binding site of the spike protein, meaning that the spike protein of coronavirus 2 has very important modifications in that region, which is responsible for binding to ACE2 receptor. And by these mutations, the binding affinity becomes stronger, and therefore we have a higher infection. And this is shown here, as I mentioned before. One important variant of concern comes from England, from the UK. And you see here the infection curve of England or UK. And as you can see, in the summer months, everything was quite okay. But then we have a rise in the infection rates. So national restrictions applied and were introduced in November. And since the government thought that these restrictions were successful, they stopped the national restrictions. So they ended on the 2nd of December. One reason was also that the government wanted to make sure that the British people can spend Christmas together and that social distancing might not be so strong anymore. As you can see, then these numbers really exploded. But even in Ireland, Ireland is neighbor. And here you see again in September, everything seemed to be under control. Then there was the first wave in Ireland, and the Irish government started to stop contacts, to close shops, and so on. And this was quite successful. And again, at the beginning of December, the Irish, again, because Christmas was standing in front of the door, and the government wanted that people can spend Christmas together with their families, grand explode. And it actually was found out that at this point of time, nearly half of all infections were caused by the UK variant. And this really shows you how infectious this new variant is. So we all, especially now in Europe, we are very alarmed that this variant can spread all over Europe. We also have found it in Göttingen as well already. And that means that we have to be very careful, because we expect that the infectious rate will be about 35 to 50% more than of the original Wuhan isolate of coronavirus of coronavirus 2. Of SARS coronavirus, and our strategy whether we have mutants or not. So as I mentioned before, we have a very large genome, about 30,000 nucleotides. And here you have the so-called, this part in red is the part which is encoding the spike protein. So in red, you have the spike protein, and within the spike protein, we have a small region which is responsible for binding to the ACE2 receptor. So it's called the receptor binding domain. And as I mentioned before, in this receptor binding domain, we have mutations. Mutations either found in the UK variant, in the South African variant, or in the Brazilian variant. So what we did in Göttingen, we established a PCR which actually is covering 400 nucleotides. And within this region, we have 3 important SNPs, exchanges of nucleotides. And when we have amplified this fragment, we then just sequence this fragment. And when we see typical SNPs, like for instance, at this position and this position, we know that we have the UK variant. If we have SNPs in this location and in this location, we know it's South Africa. And if we have a SNP only in this location, then we know that it is the Brazilian variant of concern. So at the moment, every single new isolate we identify in Göttingen is analyzed for mutations by this second PCR strategy. When we look to the dynamics of infection, we know that in the Americas, mainly United States and Canada, we have now the second wave. The same is true for Europe. In Europe, the first wave was very small because we were alarmed by the situation in North Italy. where many people died. And due to that, our government decided very quickly to close all stops to prove that people have to go into home office and so on. But then came the summer, and the Germans, the Europeans, were not very disciplined anymore, and we entered the second wave. Southeast Asia, this is not only in September, one wave, and in most countries of Southeast Asia, this was brought under control, and now it's declining. Eastern Mediterranean, we are now in the third wave, and Africa, again, also a second wave. We have a closer look to the situation in different areas and in different countries. If we look to the world, these are data from the 1st of February, rate of 1.3%, a case fatality rate of 2.2%. And if we calculate the death rate to the entire population of the world, we can say at the moment 0.03% of the world population has died on COVID-19. If we look to the USA, we have an infection rate of 8%, so very high infection rate. Case fatality rate 1.7%, so it's less than the world case fatality rate. But if we calculate the death rate of the US Americans to the entire population, it's a rather high death rate. 0.13% of all people living in the US have died on COVID-19 so far. This is rather a large number of people. And you see, we are now very near the point of 500,000 death people. In Indonesia, the infection rate still is very low, 0.4%. However, the case fatality rate is high, too high, 2.8%. And for this, actually, I myself do not have an explanation, because you in Indonesia, you are a young population. The old people die. So in Germany, you see, we also have a very high case fatality rate. But this can be explained for the population. I don't know. It might in Indonesia there are not so many intensive care units in comparison to Germany. I don't know. In Sweden, Sweden is known that it is rather an open society. There were not many restrictions, so it was always sort of a model. Can we fight Corona without strong restrictions? But as you can see, this was the wrong policy in Sweden, because the infection rate is high, nearly like in the US, 5.5% of all Swedish people were infected so far. And the death rate in relation to the entire population is 0.11%. When I look to the waves, you can see that in the world, we now have the third wave. We have a very small first wave, then we entered the second wave, and now we are in the third wave. Same is true for the United States. 3 waves so far. The last wave now is declining, what always is a good sign. And it pointed out that you still are in the first wave, but you still are not on the decline. So in Indonesia, you have to do something. There might be an even larger problem coming up for you. In Germany, we just ended, or we are just on the strong decline of the second wave. And I later on will explain to you what the German government and the German people have tried to do to fight the second wave. And in Sweden, again, we have a decline. We can say a person is infectious for other people 1 to 4 days before he develops symptoms. So it's a quite long phase of infectivity, and this makes it very difficult to control the infection. The transmission route is by droplets and aerosols, and the main symptoms are very similar to influenza. We have coughing, we have fever, a runny nose. However, in contrast to influenza, most people report that they have disorders of the sense of smell and taste. It's if you eat something like chocolate or so, it tastes like paper, many people say. The risk groups are elderly and sick people. The so-called basic reproduction number is about 3 to 4, meaning one person who is infected will be able to infect 3 to 4 other people. The incubation time is considered to be 5 to 6 days. And at least in Germany, we know that if I got infected, I have a chance of 50 to 80% that I will develop clinical symptoms. So in most cases, we have symptomatic infections in Germany. If I have to be hospitalized, it takes about 8 to 10 days. And the current therapy is remdesivir and dexamethasone. I will talk about that in a minute. In Germany, 55 to 85% who are infected develop symptoms. So this is the manifestation index. Hospitalization is needed for up to 14%, and 5% have to go onto the intensive care unit, with up to 60% who need strong ventilation therapy. So this is the frequency of symptoms in Germany. Half of the patients develop coughing, 1/3 has fever, disorders of the sense of smell and taste, every 5th patient. And we have some additional symptoms which are described. And quite important is a tendency to thrombosis, which might be a result of the hyperinflammation syndrome. And here we have a problem for children. If you see children who develop thrombosis, Kawasaki-like syndrome, then you have to be alarmed and have to see whether these children might indeed be infected by SARS coronavirus 2. These is the epidemiology situation of COVID-19 in Germany. And as you can see, most cases, most infections take place in patients who have an age of 15 to 60 years. How you see that the main problem are patients who are over 60 and even more who are over 80. So that is the reason why in Germany at the moment, when we start our vaccine old people, the next priority is this group, because we know that if a younger person is infected, there usually is not a very strong risk for death for these people. So in order to protect the old people, we start to vaccinate old people in Germany. We know that coronavirus have caused excess mortality. So it's really a dangerous disease. And you see alone in December, we have an excess mortality in Germany. Take this disease very serious. In the blue, you see the general death rate, or from the year 2016 to 2019, which has been taken as an average. And now you can see in this year, or in the year 2020, we had 29% excess mortality. What are the clinical signs in these different phases of infection? In stage 1, we have mild symptoms, we have dry coughing, and very often we have fever. In stage 2, we have shortness of breath without and with hypoxia, because in this stage, it's the lung which is affected. So we call it the pulmonary phase. In stage 3, we have acute respiratory distress syndrome, we have thirst and shock, and cardiac failure. So we have symptoms which come from all organs. Clinical signs or laboratory signs: lymphopenia, the virus. The virus destroys the lymphocytes, and therefore we have lymphopenia. When the lung is infected, we have abnormal chest imaging, and at this point of time, the liver also becomes involved. So we have enhancement of transaminases, so of liver enzymes. And in the hyperinflammation phase, stage 3, we have elevated inflammatory markers, very important: CRP, LDH, interleukin 6, dimers, and ferritin. What can we do to diagnose the disease? If you want to do a very good diagnosis, you have to do a nasopharynx swab. So you have to insert the swab through the nose. You have to go all to the throat, to the pharynx, and then you have to take out the material. Most people don't like it. It's very, very not a very good process for the people. They say, oh, it's I have some pain and so on. So several doctors do not perform a nasopharynx swab, but an oropharynx swab. But the sensitivity is by far better if you perform a nasopharynx swab. So it is quite important to do a correct swab taking. Then from these swabs, we perform the RT-PCR, that is the gold standard. And in many countries, antigen tests are also used. However, antigen tests have several problems. They have a low rate of false negatives. That's quite good, but you have to be sure that, or you have to know that if you have a negative antigen test, it does not exclude infection. But the main problem of the antigen test is a high rate of false positives. And this means that every single positive result has to be confirmed by PCR. That's a strategy in Germany, at least. Then we have serology for diagnosis. The status for diagnosis still is unclear. And serology, if you have a positive serological result, it not always means that you also have neutralizing antibodies. So the serology is still under investigation. This is the diagnosis we perform in Göttingen. We have different strategies because we experienced a shortage of plastic material, shortage of tests. So many deliver because we need to have the material coming from the United States, and the United States had blocked international trade. So we decided to buy instruments from different companies so that we can be sure that enough test systems to really guarantee diagnosis for the patients. So we have that's a Cobas from Roche and the Panther from Hamilton, from Hologic. Then we have rapid test system. We have one system Abbott or ID Now. And we also perform manual PCRs with many people. Many students help us. These are not students, these are technicians from the laboratory. And we have a so-called biosafety 3 laboratory because coronavirus 2 is classified as an S5 viruses or material which can carry this virus. We do the first steps of propagation of the material in an S3 laboratory. Very important for us is also to provide result in urgent cases. So if we know from the clinician, I need the result today, then he will get the result on the same day. So by the rapid test, we usually need about 1 hour. By the automatization, about 3 hours. If we use our hands, about 4 hours. So on this graph, you see a comparison of rapid PCR tests, and you see different publications. We have the Cepheid, we have the ID Now from Abbott, we have an instrument from Roche and from another instrument from Diazorin. And if you compare sensitivities and specificities, you usually see rates above 90%. And in most cases, people say, that's a quite a good system. But quite important is as well that you consider the positive predictive value. That means if you have a positive result, Does it mean that it's true positive or not? And the same, the negative predictive value. If you have a negative result, is it a real negative or not? We considered a prevalence rate of infected people in Germany, a prevalence rate of symptomatic patients, I have to say, of about 8%. And by calculating this prevalence rate, we are able to calculate from sensitivities and specificities the positive predictive value and the negative predictive value. And so you see by these calculations, the ID Now system has a best positive predictive value, meaning if you have a positive result, in 94% you can be sure that this result is true positive. If you have a negative result, in 98% you can be sure that it's a true negative result. In comparison, although sensitivity and specificity seems to be better than the ID Now, the positive predictive value is by far less than the ID Now in the Cepheid system. So from the laboratory perspective, it's also very important to know the values PPV and NPV. Cultivates the virus and comparing the so-called cycle threshold in the PCR, we are now able to judge whether a patient who is positive by RT-PCR still is infectious for other people. And by this investigation, we were able to show if the cycle threshold is rather high, meaning PCR takes more than 30 cycles before it is positive, we can say this patient is infected, but he seems to be not infectious to other people. That is important if you want to control the spread of the disease. So these patients who have a cycle threshold of more than 30 are not dangerous for other people, although they are infected. If you have a cycle threshold of less than 24, meaning that PCR becomes positive as an earlier point in comparison to this point, we were able in blue to cultivate the virus in most cases. And if we are able to cultivate the virus from the nasopharyngeal swab, we can say that this patient is infectious to other people. So this now is in agreement in all German institutions that we say a cycle threshold of less than 24 means the patient is a danger for other people. If we have a cycle threshold of more than 30, we say the patient is not a risk for other people. In between, we still don't know about the situation for sure. If we look to rapid antigen tests, which are quite frequently used, you see these are the data which were provided by the companies itself. I just want to focus on the negative predictive value and the positive predictive value. And you can see that these numbers seems to be quite nice. And we were confident, so we started to establish antigen tests for diagnosis as well. And our strategy was to screen the stuff with this test. If it's negative, this patient poses no risk to other people, or the stuff poses no risk to other people. If the result is positive, then the result has to be confirmed. However, we also analyzed and evaluated some rapid tests on our own. One test is the so-called Lumira DX test, and the other one is a typical lateral flow assay, the so-called Nadal test. And I don't want to go into detail, just to show you these data. In this antigen test, the positive predictive value was 47%, meaning that only 47% of all positive results are true positive results. Even worse is the situation with this lateral flow assay, where we have a positive predictive value of only 4%, meaning the vast majority of positive results are false positive results. And as a consequence, we can say that we do not use these antigen tests anymore, but we still rely on the PCR. Here, we also analyzed rapid tests for serology for determining IgM and IgG tests. So this was a rapid test which we received from China. This is a regular laboratory-based immunological test, and we just looked to the sensitivities. You see the sensitivity of the laboratory Euroimmune assay was about 50 to 60, 70%, so not really good. But even worse is the situation with rapid tests. You see a sensitivity of less than 20%, meaning that it's not useful to use rapid tests for diagnosing antigen and not useful for diagnosing antibodies. So I urgently give the advice not to use rapid tests. Although they are quite inexpensive, the performance is very, very bad. We also compared different laboratory-based serological assays, as you can see here. Here we have some tests with a very good positive predictive values and also quite good negative predictive values. So on the side of laboratory-based serological assays, there are some assays on the market where we really can put trust in it. In this slide, I want to show you some patients, 5 patients, which we followed up to 40 days. 4 of these patients were under critical conditions. 1 patient was severely sick, and we performed PCR on different days. The numbers here are always the CT values. Then we analyzed neutralizing antibody concentrations in the patients. We analyzed IgA and IgG. And as you can see, and this is a message I want to bring to your attention, is that if we perform PCR, it can happen that a PCR result is negative in between. So the green dots or fields, they represent negative results in between. This means that a negative PCR result always has to be confirmed the second day in order to be sure that the patient really is negative. And the main reason for negative PCR results in between is the swab taking. It's not correctly taking swabs. You see here as well, here we have 2 situations with a negative PCR result, later on again positive. Here, same situation. Here, the same situation. Here, the same situation. So you should not rely on a single negative PCR result in order to exclude infection of a patient. If the patient has symptoms and you think he might have COVID-19, perform another PCR on the next day. In serology, you see, although these patients all have the same critical conditions, the result of IgA is quite different. This patient presented with strong IgA results. The same is true for this patient, but here he very low levels of IgA antibodies, and same is true for IgG antibodies. And you see you have patients with strong activity of neutralizing antibodies and low activity, although both patients are under critical conditions. So making a long story short, I presented these 5 patients to urge you that a negative PCR result might be false negative, that serology behaves very different in different patients, so that we cannot rely on serological results, and that even neutralizing antibody activity differs very much, although the patients have the same critical conditions. So this brings me to the message that we still do not understand this. Well, we also try to establish new diagnostic test systems, and one strategy we try to perform in Göttingen is that we use nanotubes. These are carbon-coated nanotubes. They are very small. It's like a pulver. and we can coat these nanotubes with different receptors, with antibodies, with nucleic acids in order to detect pathogens. We already had been successful to use this strategy to identify bacterial pathogens, because these single-walled carbon nanotubes, which are covered by sensors which are able to interact with pathogens, they will transmit the light in a different way when they come into interaction with a pathogen. And at the moment, we try to use this technique in order to detect SARS coronavirus 2. It's a project which we just started, and I hope that maybe within 1 year, we have developed a new assay which then can be brought onto the market. We will see. Now I come to therapy. In therapy, we have potential therapies up to now. Antiviral therapy, only remdesivir. I will explain about remdesivir in the next slide. Then remdesivir should mainly be given in the initial phase of infection, when the virus still is replicating, meaning in stage 1. Anti-inflammatory substances like dexamethasone, hydrocortisone should be given at any stage, but especially when we have the host inflammatory response phase. So at a late stage of infection, these anti-inflammatory substances are important. The same is true for anticoagulants. They should be given for therapy at any stage, but also as prophylaxis when we know that the patient just entered the infection process. And then we have passive immunization. These passive immunization can be used by serum from former patients, but also by monoclonal antibodies. I will go into detail now and present you here. Oops, what is this? I don't know. My computer. You see what you see. Antiviral therapy at the moment, we have only remdesivir available, and remdesivir is a drug which inhibits the viral RNA polymerase, and many scientists worldwide are trying to optimize RNA polymerase inhibitors. So I guess very soon we will have other drugs which might enter the scene and can be used to treat the virus itself. So it should be given at the early stage of infection. Anti-inflammatory drugs are dexamethasone and hydrocortisone. They should be given even also early when oxygen is required, and at least for 7 days in the late stage of infection. Anticoagulation therapy, you can give whatever you know. You should have experience with these drugs, and they can be given as a prophylaxis at an early stage, but also at therapy at any stage. For passive immunization at the moment, we can use convalescent plasma at an early stage to inhibit the infection, the further ongoing infection process, or monoclonal antibodies. The US President Trump, for instance, he also received these monoclonal antibodies. And since he survived the disease, many people believe that these antibodies are quite successful. So they can be given at an early stage of infection when we still have high virus replication rate. They can be given also in patients or in people who are exposed to the virus in order to inhibit or to prevent the infection process. And they also are given as post-exposition prophylaxis, what I just mentioned, but this is yet not approved in the European Union. So you see, at the moment, we have some possibilities to treat the patients. I mentioned already the Japanese drug where clinical study is in process. There are ACE competition studies in process. So I guess within 1 year, we will have not only vaccinations, but also some drugs to treat the infection process itself. You see, you are on the zenith of a wave. In Germany, we are on the decline of the second wave. However, you have to be aware that in Indonesia, you have less numbing to stop this process. First of all, you have to test people under risk regularly, and you have to do optimal diagnosis, as I just mentioned already. For sure, you have to separate infected and infectious patients and the regular people. So social distancing is one strategy. And when you have a patient, you have to begin early and adequate therapy. But most important for prevention is to keep the base reproduction number low, to monitor and inform all people so that your people understand what is going on and that they really, that they accept all restrictions. And whenever possible, you have to offer vaccination. The basic reproduction number is very often given, and some people are not quite familiar with this term. The basic reproduction number indicates how many people are infected by an infectious person if no member of the population is immune to the pathogen, meaning if you still have a susceptible population. In this case, it's very easily understandable. If this basic reproduction number is larger than 1, it means that one person will infect more than one other person, and this means the infection will spread within the population. Is a reproduction number lower than 1, then one infected people will infect less than one other people, meaning this infection cannot easily spread within the population. In Germany, we have the strategy distancing, at least 1.5 meter, better would be 2 meters. And hygiene, whenever we have some contact with some material which might have been contact with an infected people, we have to disinfect, we have to use mask, we have an app. And when we are inside a room, we have to ventilate the room regularly. At the moment, our strategy is we calculate the 7 days incidence. If it's larger than 50 per 100,000 people, we have to restrict public life and contacts. We have to close schools. We have to close defined stores, cinemas, and so on. I guess it's similar in all over the world at the moment. If it's even larger, the 7-day incidence, larger than 100, we have to restrict travel. Some airports are closed, and we have to offer home office. So at the moment, I would estimate 20% of Germans are working at home. And to make it understandable how important it is to reduce contact, I have calculated. I bring 3 persons in one room. So if you have 3 persons in one room, you have only 3 contacts. In red, this is the 3 contacts between the 3 people. Bring 6 persons into one room, you have 15 contacts. If you bring 9 persons into one single room, you have 36 contacts. However, if you would distribute these 9 persons into 3 rooms, then you have 3 times 3 contacts, meaning only 9 contacts. So the same number of people in different rooms can restrict the contacts from 36 down to 9. And you can play around with these numbers and put more people into one room and try to separate these people, and you will understand how easily you can limit the number of contacts just by separating the people. So this is quite important to inform the people how the mathematics is playing with contacts. And then we have to use masks. And in Germany, it was quite important that the people understand the quality of a mask. An everyday mask is just used to protect other people, but it cannot protect myself. If I use a so-called surgical mask or mouth-nose protection, we have the same strategy. It will not protect myself and other people.
What?
If I have an FFP2 mask FFP stands for filtering phase piece. It will filtrate 94% of the aerosols, and without a valve, it will protect myself and other people. If I wear an FFP3 mask, we have protection of 99% aerosol infiltration, and it will protect myself and other people. Very important also is that the government is informing, the health authorities are informing the people. And in Germany, we have a web page from the government where every day we can see and analyze the situation. Göttingen is located here. So I see that in Göttingen, we have a yellow field, meaning our incidence rate is rather low. In contrast, in this region, the incidence rate is rather high. So these people have to be aware of the situation, have to keep social distancing, should not travel too much, and so on. Here in this situation, it's not that strict. We have the 7-day incidence rate. We know how many new cases per day come, how many new people have died on the disease, and we see the curve. And as I mentioned before, every day we have the map of Germany. So when we have low cases, you see all Germany was nearly yellow, like now Göttingen area, this area. And now on the zenith of the curve, nearly all Germany was red. At the moment we have this situation, so we are coming down from red to the process where some regions turn yellow. And this means the strategy of social distancing, wearing masks, and so on is working.
Prof.
Another map we will receive every day is are the intensive care units, that we see how many patients are on intensive care units. With, we say on the first curve we had 3,000 people, then we have 5,000 people on the zenith. Now it's about 4,000 people. Another information is mobility. So we can see how many people are mobile, and this mobility is targeted by smartphones. So smartphones are recorded, and by this technology, this office can recognize whether a person is traveling from place A to place B or not, or whether the person is staying in one spot. So you can see when we have the first shutdown, we also saw a sharp decrease in mobility, what is very good. So less, 40% less mobility in regards or in comparison to regular mobility. Now we have the second shutdown, again, no mobility, but the problem at the moment is that the Germans tend to become more mobile again. So mobility is quite important, the mobility of people.
Entschuldigung, Prof. I think we are short of time.
Okay, I very briefly will go into vaccination, and this will be the last step. So vaccination, different strategies for vaccination. One of the most important vaccination strategy is mRNA vaccination. And this vaccine uses DNA or RNA molecules, especially RNA molecules, which are injected into the patients. And by this mRNA, the cells are forced to produce the spike protein. So it's a harmless vaccination strategy and very effective, 95% efficacy. You have different companies from the US, from Germany, which are working together. Then we have live attenuated vaccination. This is mainly from India. It's a vaccine which is based on a weakened version of the virus. Inactivated viruses, meaning the entire virus is being taken as a vaccine. This is mainly the strategy by several Chinese companies. Subunit vaccines are not quite popular at the moment. And we have viral vector vaccines, which are provided by Russia, by UK, and as well by Chinese companies. In this case, adenoviruses are taken as a vector. And in this adenovirus, the RNA of the virus is being inserted And for this reason, the adenovirus is then able to express spike protein, and therefore the patient will develop antibodies against these spike proteins. And with this, I will come to my end. And thank you very much, Terima kasih, for your interest. And if you have any questions, you as well can send me an email. And
okay.
I am done.
Yes, thank you very much, Professor. A very interesting lecture. I guess many students are already preparing their questions. So now, first, I give an opportunity for anyone who wants to do some oral question, and later I will read the written or the chat questions. So anybody wants to ask a... Yes, Yadi, please. Dr. Yadi, please.
Yeah. Good morning, Prof. and Gross. I'm Yadi from Samarinda. I'm very happy to listen your lecture. It's very nice, very comprehensive. And to some of my questions about the CT failure. So my laboratory just right now is we test for COVID-19. We are the laboratory network for COVID-19 in Indonesia. So we test the sample from patients with COVID-19. I want to ask about the CT. In your presentation, you grouping the CT below 24, CT from 24 to 30, and CT more than 30. In the CT more than 30, you categorize that it's not infectious. So, but we know that I want to ask about why it could be non-infectious, because we know that the RNA is very unstable in environment. So if the virus is dead or inactive, we should be not detected, because in environment, the virus is very unstable. So we treat the sample in the freezing storage, so we can preserve it. But if, in my opinion, if we can still detect the virus, so the virus is still active. So
Okay.
do you have an explanation for this?
Yes.
Yes.
Please.
And the second question.
Okay, second question.
Please. We know that China is the first place this infection to begin. But if we compare to, for example, for United States and Europe country, China is still low cases. Now, do you have an explanation? China is a big country with the dense of population.
Yes.
Why?
I will first start with your second question.
Okay.
When you look to China and compare it with the US and Europe, the political systems are quite different. And in China, if the government says you are not allowed to leave your home, they did not only tell the people that you should not leave your home, but in China you have in every region, in every apartment building, you have people who control. Okay. So these people could be your neighbors, but they are very, how to say, they believe in the system, and they take care that if you should not leave the home, that you really are not able to leave the home. On TV, at least we could see that people locked the doors from outside so that people were not able to leave their apartments. They needed their foodstuff, which was brought through the windows and so on. So, and in China, whenever there was one single case, China closed up large cities, cities of 3 to 7 million people. The inhabitants of these cities were not allowed to leave their region anymore. So by very rapid and very strong regulation, people could not come into conflict with their own mind. Oh, I would like to go outside, I have a dog or whatsoever. That's, and in contrast, in Europe and in the United States, people, each individual want to have its individual right. So the government can say you are not allowed to leave your city, but you will still have several people who will leave their city. In Germany, even in Göttingen, although at the moment we should not have a party or something like that, we are not allowed to meet more than 2 other peoples at the moment. And although we are not allowed to meet other people, very often you see people who have a party with 20, 30, 50 people. The police is coming, yes, and is stopping that activity, but the discipline is different than in China. And the same is true for the United States. So it's a matter of enforcement by the authorities and the willingness of the people to accept this enforcement. I think this is the main difference which is responsible for that. Your first question is CT. You are right, RNA is quite unstable, and therefore we try, and in regularly speaking words, we are successful with that, to do the PCR on the very same day. So the swab is being taken, and the swab arrives in our laboratory usually within half an hour. So we are able to, and then immediately we perform the PCR. So therefore we can be sure that what we are measuring by PCR is still there. If I would give another example, if a transportation time takes 2 days, and in the laboratory you need another 2 days to perform the PCR, this means 4 days. Then we do not have a representative sample or a sample which represents the real situation in the patient anymore. So in this case, the CT, the cycle threshold value will not be equaling the situation in my presentation. So I agree with you, in a situation where you are not able to perform PCR on the very same day, you cannot rely on the CT in regards to evaluate the situation of effectiveness of a patient. You're right, this was a very good question. So important, if you want to judge on CT, is always to perform the PCR immediately on the same day. And another requisite would be that the sample has to be arrived in the laboratory also on the very same day.
Thank you, Prof. Thank you. Thank you very much. Thank you.
Okay, thank you very much. So is there any other who wants to ask a direct question to Professor Wu? Otherwise, yes? No?
Yes, me, doctor.
Okay, one question only. Okay, please.
Okay, good morning, Professor, and good afternoon, doctor. And thank you for your great presentation. And I want to ask a question about the vaccination of COVID-19. Is there a possibility to patients who already got coronavirus vaccine will get coronavirus disease in the future? And is the relationship with RNA mutation mechanism that make coronavirus change its strain to another, so it can make second exposure to the patient in the future? Thank you.
I don't be sure whether I understood the second question, but the first question, if I am vaccinated, is it possible that I can become infected? A clear yes. The companies which provided the mRNA vaccine, Pfizer BioNTech, was the largest company which did a study on, I think, 60,000 people, which were distributed worldwide. They measured not infection, they measured disease. So the outcome of this study was not to prevent infection, but to prevent serious COVID-19 disease. At the moment, we still don't know whether a vaccinated people, after having been infected, also is able to spread the virus. But most scientists believe yes, meaning that the immunization or the vaccination is mainly a prevention to protect people from serious disease, but it will not be a very hard instrument to stop the spread of the virus over the globe. This is at the moment very doubtful that this vaccination really will be a good helping hand. On the other side, a second important information is that most likely vaccination will protect only for 1 to 3 years, meaning like with influenza, vaccination have to be repeated most likely every second or third year. Then we do not know at the moment how good vaccination will protect against variants of concern, especially the South African variant of concern seems to be so different from the original mRNA encoding spike protein that the mRNA vaccines might not be protecting against the South African mutant. But on the other side, or on the other hand, mRNA vaccines can be adapted very quickly. Within, I would expect within 1 month, the companies can adapt the vaccine to new variants because it's a very, very quickly adaptable technique. You just have to work on the mRNA, that's it. The vectors are available. So this is a big advantage of the mRNA vaccines. But to summarize, the strategy to develop the mRNA vaccine was mainly for preventing severe disease. One is hoping that it also might help to prevent spread of the virus, but at the moment, this is rather unlikely. It's not for sure. We still have to wait the situation in Israel. Israel, as you might have heard, has already vaccinated nearly half of the population. The reason Israel has done a contract with Pfizer and BioNTech that they received the vaccine for nearly no money, so it was not very costly. But on the other hand, they had to make sure that the entire population of Israel will be vaccinated within a few months, so that now the entire world is looking to Israel in terms of preventing serious disease. This indeed is the case. And on the other hand, the second step is we have to wait for the result.
Thank you very much, Professor Will. I now go called Genos. So this Genos was developed by University of Gadjah Mada in Indonesia. Is to detect SARS-CoV-2 by blowing breath to the to a plastic bag, and then it can detect whether people are infected or no. So maybe the question is, what's your opinion regarding this new detection machine from Indonesia?
If I understand correctly, it's measuring volatile substances in the air of the patients. Yeah?
Yes. Yes, yes, yes.
Indeed, we have done a study some maybe 2-3 years ago, not on viruses, but on bacteria, pneumonia caused by some bacteria. And indeed, it is possible that an organ, after an infectious process, develop metabolites due to the disease. The problem is really the specificity at the end. At this stage of the pandemic, I'm happy about every and any new development because it will help. But as you have heard from my sentence I just have spoken, that I have some doubt about the specificity. I guess this technique will be able to help in such a way that you can understand that a patient have developed pneumonia. But at the end, I have doubt whether this technique will be suitable to differentiate between the causes of pneumonia. If you look to the lungs of patients who suffer from COVID-19 and the lungs of patients who suffered from influenza, from flu, the histopathology in the lungs is very similar. And therefore, I would expect that the metabolic consequences of the damage to the lung by SARS coronavirus 2 and influenza virus are quite similar. The clinical symptoms are quite similar. So I would have some doubt that with this machine, it is possible to differentiate between flu and COVID-19. But at the moment, nobody really knows, and it's worthwhile to follow up for sure.
Okay, yes, so it's okay to use for now, yeah, Prof. Another question is regarding vaccine. So one student asked, what if I got first vaccination from one company and then the second one is from another brand?
Yes, same questions we have in Germany, and at the moment we say the companies have all data we have available so far are coming from the big studies of the companies. And the data, the results of these studies are based on the situation that the vaccination, usually I have to get 2 doses of the vaccine, is from the original and the very same company, from the same strategy. So therefore, one cannot be sure whether the outcome is identical if I use a second shot from another company. However, due to the principle that both, if I look to the mRNA vaccines, for instance, there are 2 big companies at the moment, a third one soon will enter the scene. They all have the same strategy. The mRNA is encoding the spike protein. So my personal view would be, if I work with an mRNA vaccine from company A and will get the second shot from company B, the outcome most likely will be very similar. I even would go further on and would expect that even if I would take a vector-based vaccine as a second shot, so the first shot mRNA-based vaccine, second shot adenovirus vector-based vaccine, in both cases, it's a spike protein, which is my antigen, which against which my body should produce antibodies and T-cell specific immune response. So since in all vaccines, the spike protein is the focus for immunization, my personal view would be that it would work if I change the company from shot 1 to shot 2. But as I mentioned before, all data which are publicly available so far are relying on vaccination from one single company for both shots.
Okay, thank you very much. So it's okay then if it's available in Indonesia for changing the company, as long as it targets the same gene, in this case the spike protein, yeah, Prof. Yeah. Okay, so it's okay to change.
I have to admit my personal view.
Okay, bro. Yes, the professor, personal view. So another question. This specific genetic variant, which one is more lethal?
What is
so you mentioned about the virus is mutating, and the question is which one of the variant is more lethal than other mutation?
Yeah, very difficult to say, because so far we have no animal models which were used to analyze this question. So we just have the epidemiological data. And the epidemiological data are based on the spread of the virus. And I showed you two pictures, one from the UK, one from Ireland, where you really could see that the numbers were exploding, not only the numbers of infection, but also the numbers of deaths. In contrast, in South Africa, the South African mutant so far is mainly found in South Africa. And in South Africa, we have many people who are poor. If you cannot compare the situation, if you have the European UK mutant, which is spreading in a population which has enough food, where health systems are working properly, it might be different to South Africa, where many people are poorer, especially people who are living in slum-like areas, as an example. If you compare the Brazilian variants, this Brazilian variant at the moment is most prevalent in Manaus. Manaus is located in the Amazonas region, again, a poor region. So you cannot compare the situations, and that makes it very difficult to judge on lethality. They usually cause only mild respiratory symptoms. When they were transmitted from animals to humans 60 years ago already, it took some time of adaptation. And as a microbiologist and virologist, you also have to look into the pathogen itself. If a pathogen would kill the population, would kill humans, then it would be the end for the pathogen. And we all live because we have to replicate, we have to stay alive, meaning the virus has to stay alive. Adaptation to a new host. And we are now a new host to SARS coronavirus 2. So this virus has to adapt to ours, to the human beings. And once this adaptation has been completed, I think this coronavirus will become a harmless coronavirus. So the question is, how can we promote adaptation? And my personal strategy would be that I would try to let the virus run in the younger population, because the younger population becomes infected, but most younger people, that many young people will become infected by the natural route, we have the chance that the virus will adapt to human beings. But during this phase, and this phase can take 1 year, 2 years, 3 years, 5 years, during these years, we have to protect the old people, the susceptible people. So this would be my personal strategy. But nobody really can answer how long this will take. I'm sure the time will come. I hope that by all strategies, we will have the chance that this time will take maybe only 2 years. And the main important, in my opinion, is not vaccination, but is really to develop therapies which can fight the virus at a very early step. And there are many strategies on the way. So I'm quite optimistic. Within 2 years, we have a chance to come back to normal life again.
Amen. Okay, thank you very much, Prof. Uwe, for your explanation and for the presentation. Maybe later we can invite you again and explain some of the updates on vaccine and other data or information regarding COVID-19. So I'm also thanking to all participants that joining.
All of you. I thank you for the invitation and the audience for listening.
Yes, thank you. Yes. So I'm thanking Professor Uwe and to all the participants who are still joining our online classes. Also, I am as a moderator as forgiveness for any deficiencies. So before we leave, the committee asked for us to open all the videos so that we can have some pictures. I ask kindly to everybody to open their video. Siapa yang mau foto ya ini? Kak Rio ya?
Iya, Dr. Givari.
Dr. Kiki yang foto ya? Oke, silakan Dr. Kiki, mungkin dimulai dari halaman 1 ya. Yang foto Dr. Kiki atau
Kak Aryo. Silakan di aba-aba aja, Dr. Givari.
Ya, di aba-abain ya. Mohon dokter, tolong Kak Aryo. So we will have some guidance. I mean, Rio will tell us when to post. Kak Rio bisa hidupin suaranya?
Langsung aja Dr. Givari yang aba-aba.
Oh gitu. Okay, so the first one, yeah, okay, the first layer. 1, 2, 3. Okay, good. The second, so we have here 23. Are we going to take all pictures? I mean, maybe we can like 5, yeah. So this second one, ready? 1, 2, 3. Okay, Karyo, thank you. The third one, Rido, sini Rido. Okay. 1, 2, 3. Okay. Yang keempat, 1. Dimas mundur lagi, Dimas. Mundur dikit ya. 1, 2, 3. Okay, and the last one. 1, 2, 3. Okay, so I think we got everybody. I mean, we get 5, but I think it's enough because it's already 3 points. I mean, I think in Germany it's now 10.
9 o'clock.
9. So we start at 7.
Yes.
I thought it's 8.
There was some irritation.
Okay, sorry. I thought it was 8. I mean, I checked on Google. So therefore, it's quite early in Germany. And so again, I'm thank you very much for Professor Uwe for giving us the lecture of today. So I'm as a moderator and host for today. Again, I'd like to thanks and sorry for any deficiency. Let us close for today's session by telling Alhamdulillah. Alhamdulillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good day, Professor Uwe.
Thank you, Prof.
Very much.
Thank you, Professor.
Thank you, Prof.
Thank you, Prof.
Thank you, Professor.
Thank you, Prof.
Thank you, Prof.
Thank you, Prof.
Thank you.
Thank you, Prof.
Thank you.
Thank you, Professor.
Langsung keluar, Prof.
Terima kasih, dokter.
Ya, sama-sama.
Izin lift, dokter.
Ya, silakan. Sudah absen ya semua ya?
Sudah, dokter.
Udah,
Terima kasih
dokter.
Dokter Gifari.